Administration. It's an honor to be with you today. Thank you for the important work you do in keeping our communities healthy. Steve, did you want to say hello?
I did. I just need to unmute my microphone, but it is Zoom world. So good morning, everyone. I'm Steve Keithahn. Thanks, Jana, for the intro. Just want to add that in my work, I care for about 1,200 patients, and I also have that side gig where I worry about how to best improve the well-being of about 1,200 clinicians. Also, I've lived in Columbia for about 25 years. Before coming to MU 10 years ago, I owned a two-person private practice for 10 years, so I was an entrepreneur with that. I was also an ER doc at Boone Hospital for about 5 years, so I've had quite a few different experiences. I don't know if Kathleen Quinn knows this, but I was also born and raised in a small rural community in Minnesota, which I'll talk about a little bit later. And so I'm very excited to be able to talk with you today, and thanks for joining this session. After Craig provides an extensive background on clinician burnout and well-being, I'll be presenting ideas and themes for a process to develop strategies to improve well-being in institutions. Craig?
Yeah, and I'm Craig Rooney. I'm a counseling psychologist and the director of the Office of Clinician Wellbeing. Jana, thank you for the nice introduction. I'll just kind of let that stand. As you'll find out about Steve and I, we have a lot to say about this, and so we're going to be kind of racing the clock a little bit. I've borrowed some slides from a recent webinar called Champion of Wellness because Lottie Darby, who's one of the leading researchers in this area, spoke at the conference. And so if you see a slide with a picture of a woman talking in the right-hand corner of the screen, that's one of the slides I borrowed. We're going to cover information about a lot of different kinds of healthcare professionals. So we've tried to be careful to indicate which group of professionals that we're talking about at each time. But I'll acknowledge the literature on physicians is what I know best. But we think it's important to discuss each of these groups broadly to have a comprehensive pictures of difficulties among our entire healthcare enterprises in the United States. So please be patient with me when I'm talking about one group. That's typically how the research is done. We'll try to come full circle and talk about other groups as well. So today we'll discuss the current clinician burnout crisis and how it's been exacerbated by COVID-19. We'll review professional literature and explain the moral, business, and quality of care arguments for optimizing the workplace and taking better care of our clinicians. And then we'll, as Dr. Keithahn mentioned, he'll talk about some potential strategies, and we'll discuss stressors unique to rural healthcare. And naturally, COVID has heightened the stress of all healthcare workers. We launched our Office of Clinician Wellbeing, however, in the summer of 2019 before there was a pandemic or before we knew one was coming. And so kind of the question is, why did we do that? We did this because the problem of physician burnout has been documented for a couple of decades, but has really only recently been getting more public attention. And COVID-19 has only sharpened the focus of that attention. In a landmark study by Schanfeld and colleagues in 2012, they documented the prevalence of physician burnout. The dark blue line is the mean score of physician burnout, and it's over 40% of the physicians in the study. Some people question if the study overestimated physician burnout and wonder if we haven't become overreactive about this problem. But these findings have been replicated multiple times over the past decade and have found other variables affecting burnout, such as age, gender, relationship status, practice setting, and work hours. Burnout is not a new condition, but has long been a potential consequence from the stress expectations of working in the helping professions during modern times. The term was first used in the 1970s by psychologist Herbert Freudenberger and has since been expanded to encompass anyone with situational stress, creating the triad of symptoms: emotional fatigue, cynicism, and inefficacy. Emotional fatigue is sometimes called emotional exhaustion and is also likely what people are referring to when they talk about compassion fatigue. While symptoms overlap with those of depression and experts don't always agree on exactly the definition, burnout is always work-related. The World Health Organization included burnout for the first time in the ICD-11 in 2019 and defined it as chronic workplace stress that has not been successfully managed. While burnout is not unique to medicine and other healthcare professions, it is highly prevalent among physicians. Because the numbers of burned out physicians and other clinicians are simply much higher than those in the general population, we advocate that a specialized office such as our own is often very helpful in the struggle to fight clinician burnout. Here are the variables that put a physician at higher risk of burnout: working more hours per week, being younger, being female, being in pay structures based entirely upon billing, and membership in the specialties highlighted in the slide I just showed: emergency medicine, family medicine, neurology, PM&R, and sometimes internal medicine. Interestingly, we know that medical students begin their training with better mental health scores than their cohorts, but these scores rapidly deteriorate to being worse than their same age cohort. Residency is a key time for burnout. So younger age is a significant variable in burnout, and this may be counterintuitive as we used to think of burnout as something that affected people as they aged and became exhausted by their work. But in healthcare areas, we often see a different relationship, with residents, fellows, and younger professionals being more vulnerable to burnout. And this is often the case for nurses too. There are a lot of reasons to care about clinician burnout, and in some ways it strikes us as strange that anyone would have to make a case for taking better care of clinicians. But historically, people have not always been sympathetic to the plight of healthcare workers. We want to change that. And a silver lining of COVID-19 is that there is now a groundswell of people again considering healthcare workers as heroic and as people who put themselves at significant risk to care for others. Hopefully, this will make the work of changing our culture to one that takes better care of its healers easier work. The reasons for taking better care of clinicians fall into three major arguments: the moral argument, the business argument, and the quality or patient care argument. The moral argument for taking care of clinicians begins by acknowledging that they are simply at higher risk for suicide, substance abuse, and depression. And those clinicians who are burned out at work are more likely to be experiencing problems in their personal relationships and to have decreased job satisfaction. So put simply, we have a known risk group for significant personal suffering. And this group also happens to represent some of our most highly trained sectors of talent. And they represent those we turn to for help when we are at our most vulnerable. Burnout is an independent predictor of depression and suicidal ideation among physicians. It is correlated especially with alcohol use disorder. As you can see in these studies, burnout was correlated with a 25% increase of alcohol use disorders and doubled the likelihood of suicidal ideation. As you're well aware, it's difficult to accurately count deaths that happen by suicide, but research estimates anywhere from 300 to 400 US physicians die by suicide each year. That's approximately one physician dying by suicide in the United States each day. Estimates for male physicians are in the range of 1.41 to 2 times higher than for the general male population. And for female physicians, that range is 2.27 to 4 times higher than for the general female population. One study found that 23% of interns had suicidal thoughts. And while physicians represent the most vulnerable of all American professions, they are not alone in the healthcare sector. We also know that nurses are prone to burnout, and we're currently in a nursing shortage that makes it difficult to hire and keep nurses. And most of you are likely astutely aware of the difficulties of hiring and keeping nurses, especially during COVID. I've listed a couple of studies there. I think in the interest of time, I'll just kind of point those out so you can check those out on your own. But the Keithahn et al. Study, while getting eliminated, was over 43,000 nurses and showed that more than 40% were dissatisfied with their jobs. They were 3 to 4 times more likely than the average U.S. worker to be dissatisfied and 30 to 40% more likely to be burned out. McHugh et al. Replicated high levels of job dissatisfaction and burnout in hospital and nursing home nurses. And interestingly, a longitudinal study from last year found that among early career nurses, burnout was already affecting 12% of them in the first 3 years of their work life. And they found that burnout was associated with more cognitive dysfunction, depression, and sleep impairment. And these researchers tracked them longitudinally and found that 10 years later, those nurses who experienced early career burnout still had frequent problems with cognitive dysfunction and sleep. So this shows that overwhelming or chronic stress early in a nurse's career can have long-lasting negative effects on their health. So let's take a brief look at some of our other colleagues and team members. Variables associated with greater risk of burnout for nurses include working more hours, being younger, and having lower academic degrees. Among nurse practitioners, those who work more hours and are in an outpatient setting, and for physicians who work in emergency department settings. So we've touched on the moral argument for why we've got to do a better job at supporting medical professionals and their team members. Now let's take a look at the business argument, which is also quite compelling. As I mentioned, we're currently already in a nursing shortage, and a physician shortage is projected in the coming years, as you can see on this slide. So if our workplaces continue burning out clinicians, it will become increasingly difficult to fill the positions we need to meet society's healthcare needs. And think about this, physicians and clinicians represent the largest source of revenue in our healthcare organizations. So a crisis in our clinicians will ultimately yield a crisis in the economic health of the organizations in which we work. Dr. Stephen Beeson estimates that 80% of a healthcare organization's revenue is related to clinician work. One study estimates the annual cost of physician burnout in the United States to be approximately $4.6 billion. Struggling physicians often reduce their productivity and professional effort just to survive and often end up leaving their institution. At a minimum, it likely costs twice a physician's salary to replace them, but one industry group suggests that the cost for an institution to replace a physician could be as high as $1 million when factoring in lost revenue with recruitment and startup costs. And research indicates similar organizational consequences of nurse burnout. Increased burnout among nurses is associated with more frequent thoughts about quitting their jobs, higher turnover, and higher levels of absenteeism. According to the University of New Mexico, the average cost of turnover for nurses ranges from about $38,000 to a little over $58,000, with an average cost to each hospital at $5.2 to $8.1 million annually, factoring referral bonuses, and these numbers can quickly increase. And then another industry group estimates the average turnover cost for a bedside nurse at $44,000. And so when you look at current RN turnover rates of 16% and CNA turnover rates at 26.5%, you can see how these numbers multiply. 1 percentage change in nursing turnover can cost a hospital $306,000 per year. Burnout among physicians and nurses is also correlated with mistreatment of students and residents. So there is a burnout cost of collegiality and professionalism in our organizations. It costs in terms of what the leadership that we can expect out of our doctors and nurses. both of whom are natural leaders by definition in our organizations, both formally and informally. So if a physician or a nurse becomes burned out, they're likely not going to play the best professional behavior or role model, and they're not going to be available to those on the team who are looking to them for support, encouragement, and advisement. And then the third argument for taking better care of our clinicians is that burnout is directly tied to issues of quality and safety. So I'm going to list some things, but really let them sink in. Burnout is positively correlated with medical errors, malpractice suits, healthcare-associated infections, patient mortality, and staff turnover. And then it's negatively correlated with interpersonal teamwork, patient satisfaction, job satisfaction, and personal effort. So take a moment to let all the downstream effects of having a burned out clinician sink in. There are many more nurses than physicians and surgeons, so we cannot understate their importance in the American healthcare system. And this means there's a multiplier effect on nurse burnout that leads to poor quality outcomes in the healthcare organizations in which they work. The ACGME and the LCME and others have recognized the ill effect of burnout on trainees and have made clinician well-being and burnout part of the credentialing process. And we suspect that requirements for a well-articulated clinician well-being program will only increase in the coming years. Put this slide in because it was an interesting study by Derby et al. In 2019 that found that burnout was higher for those physicians with higher implicit bias scores. And physicians who were not burned out had the lowest implicit bias scores, and you could show improvement in implicit bias scores by assisting physicians in recovering from burnout. So given all the work we're trying to do in understanding our own implicit biases and to address healthcare disparities, this study adds another piece of complexity to those efforts, and I think lends credence to the idea of taking better care of our clinicians. So given all of these strong statistical correlations between clinician burnout and poor quality of care, some are now proposing adding physician wellness, or we would argue healthcare worker wellness, to the triple aim. Wallace et al. In the Lancet called measurements of clinician burnout the missing quality indicator. So I've kind of quickly gone over the data about why we should care about clinician well-being and the moral argument, the business argument, and the quality of care argument. So now I'd like to talk for a moment about the causes of burnout. Just kind of checking my time. This chart comes from the work of Paul Deschamps' book, Preventing the Physician Burnout. We think it does a nice job of explaining the many factors influencing clinician burnout. See that this model includes the clinician variables in the middle, the immediate workplace variables, and then all of the many variables that make up our social, political, and cultural milieu. This chart comes from the National Academy of Medicine's report, Taking Action Against Clinician Burnout, published in late 2019. It shows both the job demands that can lead to clinician burnout, as well as some of the resources that can offset burnout. And you can read these as I just share a little more information from research. But one study demonstrated that for every 1 hour of patient contact in a primary clinical setting, there existed 2 hours of administrative work. And another scholar suggested that U.S. physicians' documentation is 4 times longer than those in other countries. And put another way, we were at the Second American Conference on Physician Health, and one of the presenters noted that the longest medical records among international clinicians are often still shorter than the shortest documentation of American clinicians. So let that sink in terms of what the administrative documentation demands are on our clinicians. This graphic represents that tension between trying to balance job demands versus job resources when conceptualizing clinician burnout. And I'll show the honeycomb model to the right of the slide in more detail, and Steve will talk about it further a little bit later. This shows the Mayo Clinic's work on physician burnout. And by and large, notice that these models of clinician burnout in my last 4 slides do not place a lot of variance on individual resilience. So we set up our Office of Clinician Wellbeing not only to provide clinicians with mental health support, but also to take on structural determinants of clinician burnout as well. We think this is significant because many conversations about clinician burnout frequently focus on interventions and services built to support and bolster individual resiliency skills. But our belief is that anyone who has made it through the gauntlet of educational licensure and training and requirements to be in healthcare is likely already a very resilient person. But while we recognize much needs to change in our healthcare organizations, we also don't want to throw the baby out with the bathwater, because generally speaking, caregivers are notoriously poor at taking care of themselves. So our office does message about self-care quite a lot, not because we are blaming the victims of clinician burnout, but because we want to help empower clinicians with more tools for taking care of themselves within a difficult environment. Very briefly, a study in 2013, this was interesting, showed that 1,150 physicians, 83% reported not being burned out. But of those 83%, 70% had scores in the bottom third of a validated well-being measure. So this shows that physicians, probably like all of us, are not particularly good at self-assessing their own burnout. And while I couldn't find research specific to nurses' ability to self-assess their own burnout, my years of clinical experience suggest to me that they are likely not better at it than the rest of us. In fact, nurses' heroic role of being the glue that binds many healthcare centers together, both in terms of taking care of patients, as well as taking care of the needs of other professionals on their teams, I suspect they make nurses particularly vulnerable to compassion fatigue. But research shows that if you target all of your burnout interventions at the individual, these only provide a modest return. So those burnout interventions directed both at the individual and at the institution are much more effective. So we encourage folks to look for ways to address structural concerns like pay disparities and discriminations, or schedules conducive to having a family life, practice efficiency concerns such as reduction of administrative burdens and EHR hacks and modifications, and then an abundance of psychosocial supports. I don't think I need to go through the many and very specific challenges that faced healthcare workers during the pandemic, because I think most people on this call have lived them. But I do think it's important role that in my clinical role in our Office of Clinician Wellbeing, I've heard every concern on this last list. The all hands on deck mentality during the pandemic has left many feeling pressure to do their part, and that has really left a number of individuals also feeling very high levels of distress. And also the prolonged stress and uncertainty of the pandemic has exacerbated pre-existing mental health conditions as well. So just as an example, many individuals who were kind of cruising along successfully in their recovery were then cut off from their addiction support group and experienced vulnerability for relapse. Many folks who were managing their depression before the pandemic were not able to do many of the behavioral things like connecting to their community and socializing in successful ways. So it's exacerbated things that were well controlled prior to the pandemic. We won't spend much time on this today, but wanted to point you to this reference in JAMA earlier this year, because Shanna Felt and colleagues really did a nice job of summarizing the concerns: hear me, protect me, prepare me, support me, and care for me of healthcare workers. And it may help you in addressing some of the delayed mental health effects of the pandemic. We've been working with leaders at our institution to prepare for the fact that there is often this lag in mental health effects following a natural disaster or pandemic. And so this means many of the mental health effects of the pandemic may yet still be to come. And so we'll talk more on this later, but I want to take a quick look at the actual mental health fallout of COVID-19. The mental health disorders are on the rise in the population in general and among healthcare workers. Several surveys, including those collected by the Centers for Disease Control and Prevention, have shown substantial increases in self-reported behavioral health symptoms. According to one CDC report which surveyed adults across the US in late June of last year, 31% reported symptoms of anxiety and depression, 13% reported having started or increased substance use, 26% reported stress-related symptoms, and 11% reported having serious thoughts of suicide in the past 30 days. And those numbers are nearly double the rates we would have expected before the pandemic. The American Psychological Association Stress in America survey for 2021 was published last month. More than 6 of 10 Americans reported undesired weight gain during the pandemic. 24% of parents were diagnosed with a mental disorder during the pandemic, which included 29% of mothers and 48% of fathers reporting drinking more alcohol to cope with the stress. 77% of mothers and 87% of fathers reporting sleep disturbances. 53% of Americans have been less physically active than they wanted during the pandemic, and 47% delayed or canceled medical treatments. And so these are important to consider, because not only are healthcare workers not immune to these effects, but are likely more susceptible given the nature of the long haul of this pandemic and their proximity to it. Here's another slide that talks a little bit about essential workers. During that Stress in America survey, that 75% reported needing more emotional support and 34% receiving treatment from a mental health professional. So these are really big numbers, and it shows the mental health effects are real and are happening all around us. So I want to briefly talk about additional stressors facing rural healthcare workforces. Wadimba and colleagues eloquently articulated some of the unique challenges facing rural healthcare workers, as you can see outlined in this slide. They also noted that these challenges aren't always negative. For instance, clinicians of certain dispositions may really thrive in close-knit communities and prefer it to the anonymity of urban life. So while rural clinicians face having to navigate dual or multiple relationship, that may be more or less of a burden depending on the clinician. But these unique stressors often make the work of rural clinicians and healthcare workers difficult in ways that are unique to their urban counterparts. In their study of 473 physicians and mid-level clinicians, they found that the variables driving most of rural clinicians' work dissatisfaction were those with heavier workloads and higher levels of intolerance towards uncertainty. Those clinicians who derived greater meaning from their practice and had good relationships were more likely to be satisfied with their work. And these themes are not uncommon in the burnout literature in general, that people who are connected to others and who are connected to a strong sense of meaning in their work are less likely to become burned out in their healthcare jobs. The AHA has listed multiple other challenges facing rural healthcare delivery, some longstanding and some emerging. And while some of these challenges, such as regulatory burden and growing behavioral healthcare needs, are not unique to rural healthcare, they can certainly have a disproportional effect on rural practices because other resources, professionals, and programs may not exist to help them carry the load. Research on whether rural clinicians are more or less burned out than their urban counterparts are mixed. One study in 2019 compared physicians in rural areas, medium-sized town, and metropolitan areas, and that study found that rural physicians had the lowest levels of burnout at 25%, followed by medium-sized town at 37.5% and metropolitan areas at 51%. But it's important to know that even in this study that found rural clinicians had the lowest levels, Still 1 in 4 physicians were burned out, and that's very high. But I said the results are mixed. Another study from last year in the Journal of Rural Health found no statistically significant difference between rural and urban family physicians in terms of burnout, job satisfaction, practice environment, workload, and job stress. The study found that rural family physicians are on the average older, more likely to be male, and had broader scopes of practice than their urban family physician counterparts. In replicating other national studies, they also found that those suffering from burnout, rural or urban, were more likely to be younger and female family physicians. And so again, of note is that even though there was no statistically significant difference, the burnout levels in these groups was still 43 and 45%. So nearly 1 in 2 family physicians reporting some degree of burnout. And then finally, a study of 76 rural Kansas physicians found that 39% were emotionally exhausted, 34% were experiencing depersonalization, and just 41% felt personal accomplishment. And 22% of physicians had both high emotional exhaustion and high depersonalization scores, an indication of more serious burnout concerns. So again, they right at about 1 in 4 with pretty serious burnout concerns. Steve, I'm juggling the clock, trying to make sure I leave you enough time. So I will just say that some of the variance in the mixed finding and research on rural clinician burnout may be due to the fact that definitions of rural and metropolitan can be wide-ranging and not always operationalized similarly across research paradigms. So for instance, if a survey includes a rural county, care workers in a county struggling to provide access that's surrounded by other rural counties with similar struggles, the responses of those healthcare workers may look very different than those in a rural county in close proximity to a county with an urban center with an abundance of healthcare resources. So regardless of the variance in findings, each of these studies reinforce concern about alarming rates of burnout within our medical and affiliated professional communities. I wanted to take a mention because we mentioned several times that women are at higher risk, why this might be. One of the first place scholars have zeroed in on is work-life integration. Some say work-life balance. We don't like that because it kind of evokes an imagery of these scales and this kind of myth for most of us that work and life have to be in perfect balance. But according to Sarah Berg at the AMA, women who are employed full-time spend 8.5 additional hours per week on childcare and other domestic activities. Women who are employed and whose partners also work perform an additional 2 hours of work a day at home each day. And that's 3 times more than those hours reported by men whose partners work. Their domestic work only increased about 40 minutes per day. And research for a decade by social scientists has been documenting the disparity between men and women, at least in heterosexual couples, in terms of responsibility for domestic chores. 70% of women physicians have reported some type of gender discrimination, from disparaging and disrespectful treatment or comments, lack of promotion, disparity in resources, rewards, reimbursement, all the way through victims of being workplace sexual harassment, sexual coercion, and assault. Research has shown that women physicians have less control over their workload and schedules than men, and that women physicians in primary care spend an average of 2 minutes longer with their patients than men. So a 2018 study shows there are gendered expectations from patients that female physicians should have higher communications and empathy skills, with one study showing that patients talk more to their female physicians, reporting in appointments that are 10% longer. In some specialties like surgery, which are the highest compensated, are still largely predominantly male. In a study in the Lancet of women leaving surgery, they cited many factors, including the impact of pregnancy, the unavailability of leave, the absence of role model, and the fear of repercussions for simply pointing out these factors and acting to change them. And male physicians still earn an average of a little over $90,000 more than their female counterparts. So these are some of the reasons that burnout may affect women differentially. So phew. Everyone take a deep breath. We've gone over a lot of dire data and research findings. So knowing how widespread the problem is, what do we do about it? And so as promised, I'll turn it over to Steve to talk about processes and strategies to mitigate burnout, improve well-being.
Thanks, Craig. That was great. I was going to take a little time to talk about my hometown where I was raised, Benson, Minnesota, and give some details about that. But I'm just going to skip ahead and say that I had an amazing childhood there. I'm largely the person I am due to my upbringing in Benson, and I'm very grateful to this community for the 15 years that they nurtured me. Next slide. Craig talked about the unique challenges to well-being in rural health workforce, but I want to emphasize that there are unique opportunities as well. He kind of alluded to these also. There are huge benefits for living in a close-knit community where everyone knows your name and watches out for each other. Again, the Benson community was incredibly nurturing and warm to me, despite being in Minnesota. We had a strong sense of community and school pride. Benson was safe for us to explore in our youth once we had reached an appropriate age for that. We had good schools. Many of us went to highly selective colleges. Our school system over the years has produced physicians, attorneys, business people, teachers, clergy, professors, researchers. And then, recently online learning has brought more breadth and depth to the rural classroom, including AP classes and other opportunities. Many small town professionals enjoy the dual relationship of taking care of their neighbors and friends and do not see it as a burden. I personally really enjoy the dual multiple relationships in my practice. And yes, there is geographic isolation, but the internet, and especially telehealth, has provided access to countless resources, as Karen will tell you. Finally, often professionals in small towns are there because they are desperately needed. And so they bring a strong sense of mission to their work. But in every job, fit matters tremendously. So when you are recruiting healthcare workers, working to find a strong fit, some family who will thrive in your community is key to ensuring their well-being. And that being said, I acknowledge that the candidate pool is often limited, but I am proud that the School of Medicine here has a strong program to expose medical students to medicine in rural communities. I would argue that practicing medicine in a small community can be the best job in the world for the right physician. Next slide. So for those out there thinking about starting a well-being program or just in the initial phases of discussing this, we want to give you two crucial resources that will allow your program to make an impact as soon as possible. The first is this book, Taking Action Against Clinician Burnout, a systems approach to professional well-being. It was published by the National Academy of Medicine in 2019. It's a consensus study of the leading thinkers in this area, and you can download a free PDF of this book at the National Academy of Medicine website. Yeah, it's a tremendously valuable resource. Next slide. The other valuable resource is the AMA Steps Forward websites. Again, completely free. AMA Steps Forward presents actionable, practical toolkits and customizable resources that you can use to successfully implement meaningful and transformative change in your practice or organization. Our colleagues at Capital Regional Medical Center have successfully used the Steps Forward content to build and guide their program, and we encourage you to check this out. Next slide. As you're looking at interventions, and as we look at our interventions, we use the Stanford model that interventions fall into three buckets: culture of wellness, efficiency of practice, and personal resilience, all with the goal of having professional fulfillment. And the amount in these buckets of interventions will vary depending on the institution or organization. And again, we often personal resilience is not a third of what needs to be worked on. Often culture and efficiency of practice are the two biggies. Next slide, please. So we used this model, the 4 steps forward, to develop our organizational foundation for joy in medicine. It's key to engage senior leadership. And early on, I spent a lot of time talking to stakeholders, and we still are talking to stakeholders and keeping this issue in front of them. And I will tell you, my experience with knowledge of the programs nationwide, when senior leadership are incredibly engaged in healthcare worker well-being, or they have been thrust behind developing a program, that's when things really get done. So you really have to get your senior leaders on board. Tracking the business case for it, I think is very strong as well, and Craig alluded to that. Resources are going to matter. You can do a lot with a little. Literature suggests about $400 per physician annually. We don't spend that at our institution. Measuring wellness, Dr. Rooney will talk about that in a little bit, and then follow it longitudinally. Leadership matters tremendously at every level. Some physician well-being programs have leadership development in their title. That's how important it is. So leadership sets culture, and culture is incredibly important to the healthcare worker well-being. And then developing and evaluating interventions to optimize your culture of wellness. Next slide, please. Regarding the efficiency of practice, again, I'm sure institutions and organizations are already working on that, but developing and evaluate interventions to improve efficiency. And again, as Craig alluded to, the clerical burden and the EHR has been a tough tiger for all of us to wrestle with since its onset. And then finally, the personal resilience component of this as well. Next slide, please. So I'll refer back to the slide I showed earlier out of Mayo with this honeycomb. The goal in the center is this purple meaning and work, but these 6 components of trying to improve physician well-being with setting proper workload and job demands, having allowing for control and flexibility, optimizing work-life integration, providing social security and community at work, having organizational culture and values that are well known, and then having an efficient practice. Mark Lindsay, who developed the Mini-Z survey at Hennepin County Medical Center in Minneapolis, has shown that if a physician reports being aligned with the values and culture of the organization and practicing in a highly efficient, highly functional workplace, they have very low burnout scores. Next slide, please. So again, a little more details on the culture, some of which I've alluded to, having strong leadership at every level, having transparent leadership and communicating well. That's been incredibly important during the pandemic when so much has been changing so quickly. And we've been trying to fly the plane that we're building at the same time. Frequently communicating mission and values and keeping that out front. Some of our meetings, our leaders always start with or finish with our mission and values to keep that in the forefront. Allowing physicians and providers having autonomy and flexibility as much as possible. Dean Zweig, our Dean of the School of Medicine, who is also the chair of family medicine, one of the top family medicine programs in the country, talks about having compassion with accountability. Obviously, we have to have accountability to get the work done, but being compassionate to physicians who are going to go through periods where they struggle if they spend 30 to 35 years of their career with us. Emphasizing and modeling self-care at a leadership level is incredibly important, including that topic in your meetings. Again, almost everyone has struggled in the past year or so, including our most resilient leaders. And I think talking about how they care for themselves is incredibly important. In my work in my clinic, we really spend a lot of time talking about work family and nurturing our work family. We have the home family and the work family, but we have bridal showers. We go to each other's weddings. We support when there's losses in the family, when we're going through stress. And so we have a really cohesive work family at Woodrail, and I think that's one of the reasons we've had low turnover and we have a very high functioning clinic. And then recognizing and rewarding your healthcare workers and finding ways to do that, I think is incredibly forward. I think sometimes, especially with physicians, we take granted that they're just there, they're doing your job, and they're highly compensated. But that attaboys and support can really go a long ways. And we've tried to optimize, or we have optimized our Doctor's Day celebration. So at least one day a year, physicians really know how important they are to our institution. Next slide, please. And then regarding practice efficiency, and this was alluded to in Maria's talk earlier, having a reasonable workload and trying to maintain a reasonable workload. This concept of a manageable cockpit that they talk about from the airline industry, where a pilot can only fly a plane with so many tasks to do, they can only fly it safely if they have a limited number of tasks. And having a physician having a limited number of tasks as they get through their day is incredibly important. Taming the EMR, again, is a big issue and a real big challenge for everyone. With that documentation load that Dr. Rooney referred to, scribes have been useful. I'm sure it's going to be challenging in any institution. We're looking at virtual scribes, and some institutions have successfully utilized them, especially for certain physicians who struggle with documentation. Trying to everyone practice at the top of their license as much as possible within a clinical unit, emphasizing efficient processes, and then again, this has been worked on long before there were physician well-being programs, and then developing a cohesive team that works together. Next slide, please. And finally, with personal resilience, having a safety net, I think, is important. We have our in-house safety net program with Dr. Rooney. There are large, well-funded physician well-being programs that have opted to have outsourced online options because their physicians are more comfortable using outside online options than an inside program. So that Craig will talk a little bit about that, as well as some personal resilience online resources that you can avail yourself to. Community building is incredibly powerful and probably maybe easier in a small rural community that would be in larger communities where everyone's more spread out, there's more community and so forth. But for instance, one of the Harvard, Beth Israel, one of the Harvard hospitals, their two major thrusts when they got off their physician well-being program off the ground was to have community building, especially amongst stress groups, which for them were female primary care physicians, and it was low cost and high impact. And they also worked on taking their EMR and making it more user-friendly. And then some institutional-wide resilience training, and this can be done with 1 to 2 hour sessions weekly over 8 weeks. But what we've done, because people do struggle for time, especially over the past year, we've done some bite-sized training where, especially Dr. Rooney has done 10 to 15 minutes or less within an established regular meeting for different leadership or for different groups to give some tips on training on resilience and mindfulness. And so that might be something to encourage, and again, maybe using online resources might make that feasible and approachable. Next slide, please.
I think it's me.
Yep, it's back to you. So you'll take us home with some more online resources on mental health and personal resilience to wrap things up and get us to Q&A.
Okay. Jana, do you know when the hook is going to pull us back into the big room? Is it going to be right at noon?
It'll be right at noon.
Okay, right.
5-minute warning is going to come soon.
Okay. And we're just trying to rush a little bit to give a chance for thoughts, comments, reactions. I've been trying to attend to the chat box while you were talking, Steve, so you can review those and see if there's anything you wanted to add. I was inspired by Steve sharing his hometown, so I actually put this slide together this morning because my years 0 to 5 were spent growing up in Lebanon. And like Steve, I'm a preacher's kid too. My father pastored the United Methodist Church there, and some of my family's fondest memories are of that time. One of which was being put in a bicycle seat on the back of my mom's bike, and the entire family taking a bike ride down to Mr. Swiss, where we would get ice cream. And the Lebanon High School Yellow Jackets band would march to school sometimes right in front of our parsonage. So I feel grounded in small town America from my own roots as well. And thanks for letting me share that. We wanted to briefly share some low to no cost ways to supplement mental health support for clinicians and staff in rural areas. We know that psychologists aren't just kind of laying around everywhere. And as Steve mentioned, sometimes it's more helpful to be able to talk to someone outside of your own communities. And a couple of folks in the chat box that have asked about kind of trauma reactions, which has happened for real to a lot of healthcare workers during the pandemic. And so I don't think I'll talk about each one of these, and we'll get the slides to Lisa Branson so they can be distributed. But all of these are offering, most of them free. One of them is maybe low cost to healthcare workers, essential workers. And most of these link to actual licensed mental health professionals who can help. And so there is quite a bit out there. We don't know how long these will last free, how much of it is enhanced resources they have during COVID. But this will give you the idea of, I think, at a minimum, being able to begin to put together lists for your clinicians, other healthcare workers, so that they could access some additional support services. And this one might be the most important slide in our entire presentation today. This NAMI, National Alliance on Mental Health page, reviews all of those services I've gone over and a much more. And so I think that will be a really helpful link. And of course, we've been talking about the increased risk for suicide that we have among physicians. And so having some information about this suicide support. And again, we'd recommend giving these to your staff and not waiting for them to ask for them, so that everyone has them. And we were also curious if rural communities could partner with school and other agencies to maybe share a counselor, something like that. And we urge you to consider formally measuring burnout at your institution. This reference goes through some really pragmatic concerns about which ones to choose, and some of them are free. We partnered with the AMA in our first measure to use the Mini-Z. That was at no additional cost. So again, unless you have data, you can't really know the size of the problem at your location. Some final thoughts as we wrap up. This is from our partners at Christiana Health in Delaware. It's a concept of a triphasic trauma recovery. We would suggest to you that our organizations are coming out of phase 1 and going into phase 2, which is remembrance and mourning. And you can see from the slide, it encourages folks, healthcare systems, a chance to give their employees to talk and to share about what they've been through. Our urge will be to just jump over to phase 3 and get on with life. But we think it's important to give people adequate time to grieve and to process trauma that they've experienced. And so with that, our summary would be encouraging you to communicate transparently and frequently with your teams, destigmatizing getting help when they need it. Consider ways you can empathize with your clinicians and show concern to them. And consider how your organization can begin to build a culture of well-being, and how you can include well-being ambassadors from across the organization to begin to tackle some of the difficulty facing them. Build up your psychosocial supports, look for ways to improve practice efficiency, reduce administrative burden, and to normalize collegiality at all times to all people within the organization. We have our emails if we can help you think through some issues along the way. There are 60 million Americans who live in rural communities, and so thank you for taking care of them. And thank you for your time today.